So they are exactly like macrophages. So their structure is quite similar to macrophages, and they are syncytial also. So they got multiple nuclei as well. So under the influence of the same M-CSF, macrophage colony stimulating factor, they get converted into pre-osteoblast, and from then rank ligand plays an important role, and OPG is the opposing force in that regards, and then they develop as a syncytium of megakaryon, and from there they develop like osteoclast. So they look pretty much like a macrophage. They got pseudopodias also which are going to be attached, and then they're going to die also from that regards. So in terms of their internal structures, would they be more complicated or osteoblast? Osteoclast is more complicated. Why? They just knew them nothing. They've got only, so as I said, destruction is easier or construction is easier. So you don't need much. All they need is some enzymes to break the bone. So they got so much nuclei, so they have got less differentiation per se, and they've got shorter half-life as well. And you need shorter half-life because building is more difficult, destroying is easier. But if you continue to destroy, they will finish off the whole bone. So rank and OPG are going to control the osteoclast effect. Now, how do osteoclasts act? They first have to adhere to the bone. And when they adhere to the bone, they form tight junctions using beta-actin and integrin. If they don't form tight junction, they will be releasing their acid and also the enzymes which are going to do havoc in the surrounding area. So it's going to be only acting on that one particular part of the bone where it is getting attached, like a leech. Have you seen a leech? So it is going to just stuck to a particular part and only work there. It is not going to release chemicals anywhere else. Along with that, so beta-actin and integrin is going to work with osteopontin, and then they start their function. So they will release TRAP, which is also a form of alkaline phosphatase, which is a tartrate resistant alkaline phosphatase, which is going to start breaking up, or let's say dissolving the bone in that regards. They also produce very important chemicals like cathepsin K and matrix metalloprotease, which is going to devolve different parts of the bone. And if these are defective, what are going to happen? If you have a TRAP problem, if you have a metalloprotease problem or a cathepsin particularly problem, what is going to happen? So some parts of the bone may become harder, or maybe all parts of the bone, so osteoporosis. But in one particular condition for cathepsin kinase, you have got some part of the bone which is strong, some part of the bone which is weak. That condition is associated with significant short stature, open anterior fontanelle, broad skull, Vermean bone formation, pycnodysostosis. So all that I'm talking about have implications later on. So it's not just going to be theoretical. So cathepsin kinase, of course, is a scenario which is going to cause that. And when you are damaging, so I talked about when collagen is being formed, you have got the P1NP and P1CP, which is the C and N-terminal peptides. When it is being broken also, you have got the C and N-terminal peptide, which are known as CTX and NTX. They are markers of bone resorption. So when we talk about bone formation and bone resorption markers, we know what are we looking at in that perspective, and they go into the circulation. Now, when you are basically the osteoclasts are getting into that frenzy of producing too much, they need to be stopped. And the best signal to stop is calcium. Whenever you are destroying the bone, calcium is being released. So that calcium goes into the osteoclast and it's signaling, okay, now there's enough. And this calcium is going to be built up a lot in the osteoclast and it's going to destroy the osteoclast. So within the osteoblast activity, I said there is the linkage telling osteoclast to start acting. And within the osteoclast activity, it's already destined to die. So like all of us, there is a whole cycle which is written. Okay, you start working and then ultimately you will die. Now, what should you do from there? If you have destroyed bone, what do you want? Nimisha. Yes. So what is going to happen? So there will be signals which are released which are going to bring back the osteoblast. So there is a continuous cycle of construction, destruction, and construction. And there will be internal pathways which are regulating that. And OPG has got the opposing effect which is there. So within the osteoblast, we talked about two pathways which are going to work. One was the RANKL pathway and the Osteorix pathway. Here there's a struggle between the OPG and the RANK ligand. So RANK ligand are going to increase the osteoclast activity, while OPG are going to suppress that. RANK ligand is in turn regulated by the PTH and PTH-RP. So what is the major site of effect of PTH? So primarily PTH is going to act on the osteoblast. And from the osteoblast, it is going to increase RANK ligand. And this RANK ligand is going to act on osteoclast. So while we say PTH is going to increase the bone resorption, it is primarily acting on the osteoblast. And that is why bone formation is already there. So increased turnover happens from that regards. RANK ligand is also increased by calcitriol. And I've already said that if there is a calcium depletion, it is going to cause bone resorption to produce calcitriol. And thyroxine is also going to have an effect from that perspective. What is the effect of cortisol in the overall bone metabolism, Nimisha?
The bone resorption.
And so what are the ultimate effect if you look at from on calcium, on phosphorus, on osteoblast, osteoclast, what does cortisol do? So let's say calcium, what does it do? It will decrease calcium. It will also decrease calcitriol effect. It is going to increase the osteoclast activity and it's going to decrease the osteoblast activity. So cortisol excess is more of decreased bone formation, increased bone resorption, which is going to be the major factor from that regards. The major determinant of OPG, however, is estrogen. So if you compare estrogen versus cortisol, they are basically the opposite. So estrogen deficiency, typically what is the most common cause of osteoporosis globally?
Common cause. Estrogen deficiency.
Menopausal, that is the most common cause. So every female will have the menopausal. Yeah. No, so but if you talk about how many people have osteoporosis, most common will be females. 90% are female. So the major factor is estrogen deficiency, and estrogen deficiency is basically causing less amount of OPG, which basically means your osteoclasts are going to work more from that regards. And calcitonin is also going to act from that perspective, and we know calcitonin plays a role because it's also effective in treatment of hypercalcemia. Bisphosphonates also act via the OPG pathway. So as we discussed, if you think about therapeutic options for osteoporosis, you can either increase osteoblast, which we have talked about the RANKL pathway or the other pathway, and the PTH, which is going to work through that pathway, or you are going to block the action of the osteoclast using RANK ligand inhibitors or the OPG. So this will be the major mechanism. Then we'll talk about that in a bit later perspective from that regards. TGF beta and interleukin are also going to work from that perspective. Now, finally,